A very warm good evening. Thank you so much for joining us this evening. I wonder, have you ever been in a demanding, challenging role where you found yourself caught up in the whirlwind of responsibilities, decisions, and just constant multitasking? If you are like me, you've had those several competing priorities squeezing your time till you've hardly any minute to focus on you and your well-being. As the old saying says, health is wealth. This can't be more truer for us as female leaders, with our families, with our colleagues. This evening, we are discussing about cancer awareness. Our focus is on the breast, on the cervix, and on the prostate. And this is an opportunity to gain insights into cancer awareness because early detection and prevention will save your life. So this evening, we are prioritizing our health and well-being as leaders. And we want you to invite your family and colleagues so that we can join in this conversation and take a better step towards a healthier, more balanced person. Allow me to introduce myself, those who are joining us for the first time. My name is Lois Muteti. I am a dedicated coach on a mission to empower and uplift female leaders who are navigating that complex journey of life and leadership. And in this world of all those competing priorities that we find ourselves lost, overwhelmed and stuck, my purpose is to guide you towards self-discovery, clarity, and unwavering confidence. I have made it my life's mission to be a beacon of support, and that's why we are here as the Woman of Excellence community, as a guide through these turbulent waters of uncertainty, and to be that catalyst for transformation. One of the platforms I support women is this platform, Woman of Excellence, which is an online community with hundreds of ladies. Other platforms that you may be aware of is the book club. We call ourselves I Am Leading Book Club. We also have another platform, the Rich and Royal Abundant Ladies. And of course, several personal coaching programs that I offer. In all this, my passion is to help women break free from the constraints that hold them back and enable them to step into their true potential and lead with unshakable confidence. So part of this transformation, ladies and gentlemen, is wellness and health. And this is why we are here this evening. I know no one of us has never had one family member or colleague or friend who has, someone who has had one of these cancers, either cancer of the breast, cancer of the cervix, or the prostate. That's why we are happy to have partnered with Scion Hospital to bring this information to us, because when we know that when we empower ourselves and we are able to navigate through those turbulent waters of life, then our lives and our health will be much better. Remember that health is one of the greatest gifts that God has bestowed upon us. We therefore have a responsibility to take care of our bodies and mind. Ladies and gentlemen, join me on this transformative journey this evening and help me welcome Miss Nancy Bessa of Scion Hospital, who will introduce the guest speaker for us. Nancy, are you in the house? Kindly introduce our daktari, and then daktari will take over. Asante sana. Nancy?
Thank you, Madam Lois, for this opportunity. Good evening to you all. My name is Nancy Bessa. I'm from Scion Hospital. I thank you and I fully invite you and to this educative webinar. So I'm from Scion Hospital and I really welcome you all. And I kindly welcome our doctor, Ms. Dr. Benoit. Welcome and take over. Welcome all.
Thank you so much, Nancy. Karibu daktari. This is your time and opportunity. We can't hear you.
Can you hear me now?
Yes, we can. Thank you.
And can you see the screen?
Yes, we can.
Okay, so thank you very much. Good evening, everyone, again.
Thank you.
So
good evening.
I'm going to be going through an overview of the breast cancer, cervical cancer, and prostate cancer. Just the key facts, then we are going to have a question and answer session where we can talk and learn more. So that's the outline. Basically, we'll be going through an introduction, risk factor, and diagnosis and treatment for each of those three cancers we've talked about. So as an introduction, I want us to know that cancers are a major public health problem, especially in the sub-Saharan Africa. By saying that it's a public health problem, it means that cancers now eat into the budget of countries. They have they eat the majority share of the budget of these countries in sub-Saharan Africa, as far as their treatment and diagnosis is concerned. So this burden is mainly due to two factors. So number one, it's mainly due to demographic transitions. So demographic transitions, by this we mean that people are nowadays getting older, which means we now have people having diseases of old age. And then the second reason is actually changes in the lifestyle of people. Changes in lifestyle, it is mainly brought in by the fact that some years ago, people were active. People used to walk several kilometers to go to their farm. But nowadays, and once they are in their farm, they would do physical activities that actually require one person to be active. In recent times, that has changed a lot. In recent times, people are sedentary. You find that somebody drives to work, reaches work, steps out of the car, walks few meters and is into the office, sits the whole day, goes back at home, has nothing cooked or ready, so they buy some fast food on their way home. So such things. And then nowadays, things like alcohol, cigarettes are very much easily accessible. And these are actually the changes in lifestyle that we are talking about. So as far as the number goes, let's talk about new cases. So we are not going to go into the exact number, but this is a pie chart showing the new number of cancers, new cases of cancer cases that were recorded in Kenya in the year 2020. We can see that breast cancer accounted for about 16.1% of all the cancers. And then cancer of the cervix accounted for about 12%, while prostate was in number 3, accounting for about 8.1. So this is why we chose those three cancers. They are the most prevalent cancers as far as Kenya is concerned right now. So that having been said, let us look at now when we separate the genders. We can see that prostate is of course leading, accounting for 1 in every 5 cases of cancers that are reported in Kenya. Those are the ones that we know of. So while we are on that, we have cancer of the esophagus following closely and other cancers. So finally, we look at new cases. So new cases in women. We can see that as far as women are concerned, breast cancer accounted for about a quarter of all the cases that women got. While cervical cancer here in Kenya was number 2, accounting for about a fifth, 20% of all the cases. So out of all the cancer cases for women, we can see breast accounted for a quarter, while cancer of the cervix accounted for a fifth, that's 20%. So let us look at which cancers kill people. Because as we'll come to see, some cancers you might get them and live with them, while others, if you get them, it's more of a death sentence. So these are the ones that we really need to avoid. So top 10 cancers that killed people in Kenya in 2020, we can see that the prostate cancer is on top there. The cervix followed, the breast was in number 3. So these cancers, they are deadly. We are not just taking them at face value. So this is the same information showing how much the prostate cancer has a higher mortality rate. So now we can talk about the breast cancer. Please, if you have questions, it's good to note them so that we can answer them when the time comes. So breast cancer. As an introduction, it's a very common cancer in females. But something to note is that when it is found and treated early, breast cancer is curable. The keyword there being curable, and the keyword being that it should be found and treated earlier. So breast cancer deaths have decreased over the last, over one-third in the past 3 decades. And this is mainly due to increased increased screening and improved treatment. So early detection and treatment improves survival. We've already talked about that. And then we can see that breast cancer usually starts in the glands that produce milk, that's the lobules, or the tubes that carry the milk from the glands to the nipple. So it's actually quite difficult to detect. By the time we reach the stage where it has a mass in the breast, we might be too late. Yeah, so we are going to see what are the early signs that you can actually identify and you can actually go and get screened. Now, something to note.
You've gone off, Daktari?
Yes?
Gone off. Okay, now.
Are we back on right now or we are still off?
We okay now?
We are okay?
Yes.
Okay. So risk factors. So many risk factors of cancer cannot be changed but can be modified. So breast cancer can occur in women with no identifiable risk factors. So it doesn't mean that if you have any risk factors, you get scared, because the risk factors don't mean that you'll get it. So the standard risk factors that we talk about are increasing in age. So breast cancer is very rare in women who are below 40, and also pretty rare in women who are below 60. So increasing in age is the #1 risk factor. So the other risk factor is women who are obese. And it's obese especially in menopause, which means we have to work hard. By the time we reach menopause, 50, 55 years old, we are lean. This also affects women who are taller, and it can affect women who had other breast diseases earlier on. So if a lady comes to you, or you know a friend who had some issues with the breast, they tell you, I went to see a doctor because my breast had issues. These are people who are more at risk for getting cancer. Now, sometimes we talk about using contraceptives or hormonal therapy. What I want to assure us is that this is safe and only proves to be a risk factor for people who use hormonal therapy for more than 5 years. That is swallowing the contraceptive pills every day for more than 5 years. That's when this becomes a risk factor. So other risk factor, now these are actually serious risk factors. So family history. For people who have a personal history of getting breast cancer, probably you got breast cancer in one of the breasts, then the other getting breast cancer in the other one, you are at an increased risk. If you have a first-degree relative, that is a mother, a sister, or a daughter, or even we are talking of fathers and brothers, because we all know that even men can get breast cancer, you are at 20% risk compared to the general population. If you have breast cancer susceptibility genes, that is BRCA1 and BRCA2, you are 45 to 70% at higher risk than normal population of getting normal cancer. So nowadays, we even have genetic testing where we can see whether you have these genes, and treatment can start early. So if you are at if you have increased breast density on a mammograph, so this can only be found on a mammograph. When you do the X-ray of the breast and they tell you that the breast tissue is denser than usual, then you are at an increased risk, and actually we'll see how you are managed when this happens. Now, another risk factor is for those who get their first period early and go into menopause late. By first period early, we mean people who get breast cancer, who start their period when they are below 12 years old, and those who reach 60 years old and they are still having menses. Those people are at an increased risk of getting breast cancer. Now, pregnancy and breastfeeding, we had to put that one there, but actually this is not a risk factor per se. This is what is known as a negative risk factor. Women who give birth, women who breastfeed, decrease their chances of getting breast cancer. And then lifestyle factors, we've already talked: sedentary lifestyle, inactivity, obesity, smoking. Those things are at risk. They put one at risk of getting each and every cancer. So how do we diagnose breast cancer? So we diagnose breast cancer, #1, by observing the breasts. So if you have any abnormal lump or any other changes in the breast or the armpit, so the armpit is also of importance, then we should have that one checked. So the changes that I want us to be looking out for, the changes that we need to talk to our friends about, is dimpling in the skin over the breasts. So whenever you see any skin changes over the breasts, don't take that one lightly. Get a mammograph, and if there is anything, we proceed forward. So don't wait until you have a mass inside the breast. That's a very late sign. Change in the size or shape of one breast compared to the other one. So whenever there are those changes, one breast becomes smaller than the other or becomes bigger than the other, please get checked. Retraction of the nipple, that is pulling in of the nipple when it was previously pointed out. Those are the early signs of a breast cancer that we need to check out for. And then bloody nipple discharge, or any discharge from the nipple for that matter, we need to have it checked. And then we have discoloration on the skin of the breast. Those are the early signs of breast cancer. And these are the ones that we want to check out for. Because the late signs, when the cancer has already spread, where you have difficulty in breathing, you now have a breast that looks like it's infected or it's painful, those are late signs. We don't want to catch the cancer when it's there. So here we have a characteristic feature, a characteristic of breast cancer. This is called peau d'orange. Peau d'orange. So peau d'orange actually is French for skin of an orange. So we all know an orange when we go to the market and we pick up an orange. So whenever we see the skin of a breast becoming like the skin of an orange, the fruit orange, then we know that that is characteristic of breast cancer, and we actually need to act on it. So other things I want us to note here is that the nipple in this picture is retracted. It's no longer pointed out. There is an ulcer or a wound around the nipple. We can see a yellowish discharge around the nipple, and of course the skin changes that we've talked about. That is the skin of an orange. So those are the early signs, and those are the things that's when we want to catch the breast cancer. So assessment of a breast lump. Whenever you get any of those changes, you want to start by a mammogram. So mammograph, it's the same thing, and that basically is a is an X-ray of the breast. Once we do that X-ray and it rules out any problems, then we are safe for the next 2 to 3 years. But if there are any problem, then we can proceed and ask for a breast ultrasound. An ultrasound is better in identifying any masses or identifying whether, remember we said that breast cancer begins in the lobules. Those are the tubes that carry breast milk. And it's able to see whether the lobules have become bigger, that they are dilated, which might be a sign of cancer, or the lobules have fluid in them in a lady who's not breastfeeding. So finally, if the ultrasound also suggests that we might be having some abnormality, we can do what is known as a biopsy. So a biopsy is taking, there are several ways of taking a biopsy. We can take a large needle and insert it in the breast, and actually whatever will come out, once we pull the needle out, we take it to the lab for it to get checked. Or you can do a small surgery where you pick a small tissue of the breast and you send it to the lab for it to be checked out. Now, what we need to know is that up to 10% of breast cancers are not visible on either a mammogram or an ultrasound. So if you are having a premonition that things are not okay, that your breast has changed, please have it checked out. Final diagnosis can only be made using biopsy. So, when do we screen? Remember, the goal of screening is to find cancer before it's detectable, or if the cancer has occurred, to find it in a very early stage, because we see that when we treat cancer before, the outcomes are better. So breast cancer is more easily treated and more likely to be cured when it's caught earlier. So average risk women. Now, I think after this, through the charts, I'm going to share a website where you can actually calculate the risk so that every lady can know whether we are in average or high risk. So for average risk, of which that's about 98% of all women, we start a mammograph or mammography, that is the chest X-ray, is the recommended first line. We start it at the age of 50 years, and then we repeat it every 2 to 3 years until 75. If you reach 75 and there is no problem, then there is no need to worry about breast cancer. So other screenings, there is self-breast examination. We've already talked that we need to check on our breasts so that we know them. If we see any changes, we act on it. You can also do an ultrasound or an MRI. That is for younger ladies. That is a lady who's below 37 years and you're thinking, and is a high-risk lady. These represent 2% of the population. They are not very many. Or women with denser tissues or who have high risks. We've already talked about that. So breast exam, how do you do a self-breast exam? Because that's very important. Now, there are 3 methods of doing a self-breast examination. The first method, as you can see from the picture, you go in linear lines. So the lines are parallel to each other. You come from up to down, then the second line goes through the nipple and the third line goes through the outer side of the breast, as you can see the arrows pointing. And then finally, you should touch your armpit. The second method is called wedges. So the center line is the nipple, and then you draw about 5 to 6 lines, all pointing towards the nipple. And then you touch along those lines that finally meet at the nipple. And if there is any mass that you feel, you can have it checked. The third one is a circular motion, where you start from the middle, that is the nipple, and you go around as you move away from the nipple until you examine the whole breast, and then you end up in the armpit. So that is what should be done, and self-breast examination should be done by both men and women. And this emphasizes the fact that we should be familiar with our own breasts. So treatment of breast cancer, this one I'm not going to spend a lot of time on it, but what I want to say that treatment of any cancer is a multidisciplinary approach. You cannot have one doctor treat you over cancer, because there, as you can see, there are very many different methods of treating cancer, and each method has its own specialized doctor. So in the early stages, what I can say is that breast cancer will get treated by surgery, which means if you have breast cancer and it's in the early stages, you will go to an oncologist, that is a doctor who specializes in management of cancers, but they'll send you to a surgeon. And the surgeon can either do a mastectomy where the whole breast is removed, or they can do conservative breast surgery where they remove the lump. After that surgeon has done the breast surgery, they will send you to a reconstructive and plastic surgeon so that they can restore the beauty, which is the breast of the lady. If the breast cancer is in its last stages, then we can try it's in advanced stages, we can try other methods, which include radiation therapy, chemotherapy, that is using of medication. There are some cancers, not all of them, a very small percentage of cancers that are hormonally induced, which means if we stop the production of one specific hormone called estrogen, then actually the cancer will get cured, which means hormonal therapy is part of it. Targeted therapy and immunotherapy, these are very expensive methods where we change the person's immune system to make it attack the cancer cells. Okay. So once this treatment has been done, something that is of importance is that people who are at high risk of getting breast cancer, they can take a medication known as tamoxifen, and these ones, they take it for a lifetime to prevent cancer from recurring. And this medication has also been used in people who have high risk, like the ones who have the BRCA1 genes, and 3 or more relatives who got cancer, breast cancer. They're also given this medication to prevent them from getting breast cancer. And then finally, we also need to connect the people who have breast cancer with the clubs and social clubs, welfare groups that support cancer survivors. So that's very short, and it's about breast cancer. So I am going to answer all these tweets, all these chats that I'm seeing. Thank you. Keep the chats coming in. Okay. So let's go to something that I want to finally talk about breast cancer is the prognosis. So this is the 5-year survival rate after treatment of breast cancer. So once the breast cancer is found and is still localized inside the breasts, the 5-year survival rate is 99%, which means if we find the breast cancer and it's still localized in the breast, those are skin changes, a retracted nipple, a breast lump, that is a swelling in the breast, then 99% of all those people live up to 5 years. Once the breast cancer has spread to region, now the region that you are talking about is you have your breast cancer, but you can actually feel a swelling in the armpit, then the survival rate drops to around 85%. And regional breast cancer is also treated using chemotherapy and radiotherapy. Those treatments are very severe. So once the breast cancer is distant, that is, it has attacked the muscles under the breasts, survival rate up to 5 years is only 30%. And once it's gone up to the lungs, survival rate is actually less than 1%. So that's why we need to catch breast cancer earlier when it's in the early stages. Let's talk about prostate cancer. This is for the men. This is for our fathers, our husbands, and our brothers. So introduction is that the prostate is a small gland that carries sperms, produces the fluid that carries sperms during ejaculation. So that is the work of the prostate. While the sperms come from the testes, the fluid that the sperms swim in comes from the prostate. So this gland sits below the bladder, that is in men, and is in front of the rectum. So basically, this prostate sits where in females we find the uterus. That's where the prostate is for men. But this prostate forms a ring around the urethra. We will come to see why this is important to know. So another thing is that prostate cancer occurs most often in men who are older than 50. Although prostate cancer is very common, most men do not die from prostate cancer. This is because prostate cancer usually grows very, very slowly. But you still don't want to have it. Huh? So that's a diagram of where the prostate is found. So we can see that the prostate, this is the bladder, the one that holds our urine, and then it's found just below the bladder, and it surrounds the urethra, which means the urine when it's coming out of the bladder, it passes through the prostate gland, and then it comes out. So this is enlarged, so the prostate gland is here, and the bladder is up here. Okay. Risk factors. So we can see the number one thing is age. So prostate cancer occurs in men who are above 50 years old. Family medical history. So if you have a first-degree relative, that is a father or a brother, or a female relative with breast cancer, since these two are related, so you might be at higher risk. And diet has also been implicated. So people who have a diet that is high in animal fat and low in vegetables, they are at higher risk of getting prostate cancer. Symptoms of prostate cancer, it is usually asymptomatic because it grows very, very slowly. But once it has occurred and it is reaching in the last stages, it may be difficult to urinate because we've seen that the prostate forms a ring around the urethra. So it may be difficult to urinate, or you may need to urinate more often. And then the urine stream is slower than usual. So this is called hitting the wall. When boys are young, they are able to hit higher on the wall, while as men grow older, they can no longer point the stream of their urine high on the wall. So these symptoms can be caused by other conditions, not just prostate cancer. Actually, the most common condition that causes this condition is a condition known as benign prostatic hypoplasia or enlargement, BPH. And that one is very, very common, and it causes the same symptoms as prostate cancer, but it's not prostate cancer. So screening for prostate cancer. Testing for prostate cancer in men who have no symptoms of the disease. The standard screening tool is a blood test known as PSA. PSA stands for prostate specific antigen. So screening, it's advisable that it starts from the age of 45. So let's go talk to our uncles, our fathers, who are 45 years old and above, that they need to consider screening for prostate cancer. How often? Once you start screening, it's done every 2 years. When do we stop screening? At 69 years old. Once you reach 69 and you've not gotten prostate cancer, like we said, it's a slow growing cancer, which means you might never get it at all. So sometimes screening is not recommended, especially for prostate cancer. So for people who have life-limiting diseases or limited life expectancy, it's not recommended to have screening for prostate cancer. And then sometimes when the potential benefits of screening outweigh the likelihood of the likeliness of the harms. So these are patients who probably, even if you screen them, they cannot undergo the surgery. Like we said, these are cancers that develop in people of old age. So if somebody is probably 75 years old or even 65, but you see that they cannot withstand the surgery for prostate cancer, then it's not recommended that you screen them. And then screening for prostate cancer has some specific things that you need to do so that the screening tool is more accurate. For example, you need to avoid any sexual contact 48 hours before the screening. And like we said, the prostate sits below the bladder. So things that might excite the prostate, they include things like riding a bicycle. So you need to stop all such activities 48 hours before the screening is done. Diagnosis. Whenever we find that the PSA, prostate-specific antigen, is very high, then we can do what is known as a digital rectal exam, where we actually try and feel the prostate using the fingers. And then finally, you can do follow-up, that is a biopsy. You go to a surgeon who actually does a minor surgery to take part of the prostate so that it can be sent to the lab. We also can do an MRI and an ultrasound so that we actually visualize how big the prostate is. So, what are our treatment options? We've already seen that prostate cancer is a slow-growing cancer. Among the treatment options is active surveillance, also known as watchful waiting. So we continue examining the patient, we continue examining the man and asking them how do they feel? Do they have any symptoms? We continue doing serial ultrasounds to know whether the prostate is becoming bigger. If the cancer is growing at a very slow rate, then men can actually live with it. So something to note is that more men die with prostate cancer than dying from it. So if you were to, this statement came from somebody who actually did biopsies on men who have died of old age and found that a very good number of them already had prostate cancer, but they were not aware that they had it. So other options include surgery. In surgery, we can do a prostatectomy where you remove the prostate gland. And then other options for late cancer include radiation therapy, Hormonal therapy. In hormonal therapy, you actually do what is known as BSO, that is bilateral subcapsular orchidectomy, sorry, where you actually remove the testes, therefore removing all the sources of the hormones, and that can cure prostate cancer. And in the end, we can do chemotherapy, which is giving medications that fight cancer. Now, let's finish with the cervical cancer so that thereafter we can actually have an question and answer sessions. So, sorry about that. Before, let's talk about prognosis for prostate cancer. So, prognosis is for most patients with prostate cancer, especially when it is localized or regional, is very good. So, life expectancy for older men with prostate cancer may differ a little from age-matched men without prostate cancer, depending on their age and their comorbidities. Now, we can go back to cervical cancer. Let's do our introduction. So the cervix is the bottom part of the uterus where it meets the vagina. So cervix is actually a Latin name that translates into neck. That's why the bones in the neck where the head meets the chest, they are known as cervical. They are known as the cervical bones, cervical vertebrae. So cervix actually means neck. So the cervix is actually the neck of the uterus and the vagina. That's why its full name is actually cervix uteri, the neck of the uterus. So most people who have cervical cancer is found and treated early, they do well. So cervical cancer, if it is found and treated early, most people do well. So these are the organs, the female organs. So these are the female organs that we find in the pelvis of a female. So we can see our uterus, and we can see that the cervix is the part that connects the vagina and the uterus. Okay. So let's go straight to risk factors. So risk factors, we divide them into two. There are HPV-related factors and non-HPV-related factors. So HPV is actually an abbreviation for the name of a virus. HPV stands for human papilloma virus. And human papilloma virus is implicated in 99.7% of all cervical cancer. So let me repeat that so that I actually emphasize it. Human papilloma virus is implicated in 99.7% of all cases of cervical cancer, which means if we can eliminate this virus, we can eliminate cervical cancer altogether. Are we together on that? Okay. So, risk factors for cervical cancer, they are the risk factors that exist for getting the human papilloma virus. So one of the risk factors is early onset of sexual activity. So it was found that people who got cervical cancer, a good number of them were sexually active before they were 16 years of age. So people who have multiple sexual partners, that is a risk factor for getting cervical cancer. People who have a high-risk sexual partner. So if you have a sexual partner who has multiple sexual partners, that is who we call a high-risk sexual partner, which means you become at high risk. You also become at risk of getting HPV, and you become at high risk of getting cervical cancer. So history of having a sexually transmitted infection, that is another risk factor for getting cervical cancer. Early age at first birth. These are people who give their first child, who get pregnant, or rather who give birth to their first child before the age of 17. So history of vulvar or vaginal lesions. If you have any lesions, then you might also be at high risk of getting cervical cancer. And remember, cervical cancer, since it's brought about by a virus, and a virus is an infection, anything that reduces your immunity will make the virus, the HPV virus, become established as an infection, which means you're at high risk of getting cervical cancer. And the most common cause of immunosuppression is HIV. Of course, we have other medication like the cancer medication we give, chemotherapy, radiations, they also cause immunosuppression. So non-HPV related factors, for some reason, cervical cancer is common in people who are poor, low socioeconomic status, people who use oral contraceptive for more than 5 years. This is still debatable. I mean, what are you using the oral contraceptives for? Those who are cigarette smokers, and those genetics also plays a role. If your first degree relative is having first degree relative got cervical cancer, and then those people who have an uncircumcised male sexual partner or partners. So that's another risk factor. So symptoms of cervical cancer. So like we said, most cancers in their early stages, they are asymptomatic. But once they become symptomatic, usually that's a late stage already. But the most common symptoms for cervical cancer are abnormalities in vaginal bleeding. So you get bleeding in between menstrual cycles, bleeding after sex, that's a telltale sign for cervical cancer, and then bleeding after menopause. So something we need to know is that these symptoms might occur not necessarily caused by cervical cancer. They may be caused by other cancers, and they may be caused by other causes, not cancers, which are not cancers. In the later stages where the cancer is big, we might have a foul-smelling vaginal discharge, pelvic pain. We might get difficulty in urinating as it attacks the ureters. And those are really the final stages. Kidney failures, it might come in, and we don't want to reach there. So diagnosis of all cancers, like we've said, it starts with doing a biopsy. So here you start by having an abnormal screening test. We are going to see the screening test. And then once you have an abnormal screening test, you are sent for something called a colposcopy. Colposcopy is where we magnify the cervix and we are able to take a small tissue and send it to the lab. The small tissue, we call it a biopsy. So we have some food for thoughts. These are statistics of Kenya versus statistics of USA. And here we are talking about cervical cancer. So we can see in the US, the year is 2020. The number one cancer in the US with a rate that is about 126 per 100,000 population is breast cancer. Number one in the US. Number two in the US is lung and bronchus, basically things that are in the chest. And here we are talking about women, ladies only. And then we have colon and the rectum. So basically the intestines. Number four, we have what is known as cancer of the uterus, that is the endometrial cancer. Number five, we have thyroid. And then we continue. And then when we reach the cervix, it's number 13 with a rate of 7.7 per 100,000 in 2020. So cervical cancer in the US or even the West, generally speaking, Europe, it's not even in the top 10 cancers that they worry about. They have forgotten literally about it. And actually, when you check about this cervical cancer in the West, at number 13, it affects what the West calls marginalized population. So those are the refugees that reach there, the undocumented people, the homeless, the old, the neglected, people with mental illnesses. Those are marginalized populations. Those are the ones that get cervical cancer. Now, let's come back to Africa. These are the statistics from Kenya, which actually are very similar to what is seen in all sub-Saharan Africa, in sub-Saharan African countries. So you remove the countries that are in the north, the Libya, the Egypts, and you remove South Africa, the remaining countries in Africa are lumped together as sub-Saharan countries. We have breast as number 1, of course, and then cervical cancer is number 2. Cancer affecting us here in Africa, while in the West it seems that cervical cancer is not there. So we go back to our risk factors. We can see that 99% of the cervical, 99% of cervical cancer cases occur due to the virus that is known as HPV. And we know that HPV is a sexually transmitted virus. So does it mean that we are more sexually active compared to them? Well, the answer is no, not really. I think also in Europe and USA, those people are pretty much sexually active and they engage in as much as dangerous sexual behaviors as we do in Africa. But the key main factor here is we said that if we can eliminate HPV, we can eliminate cervical cancer. How do we eliminate HPV? It's a virus. Viruses are generally eliminated via vaccinations. So let us embrace vaccination for HPV virus. Okay. So screening for cervical cancer. How do we screen? So remember, the goal for screening is to find the cancer in its earliest stage or even before it becomes a full-blown cancer. That is when you have what is known as precancerous lesions. The standard screening tool is a test known as a pap smear. A pap smear can be combined with testing for the virus that we've just seen, HPV virus. When do we recommend starting of the screening? We recommend that screening starts at the age of 25. How often do we repeat screening? Every 3 to 5 years. When do we stop screening? At around 65 years, or when you have a surgery that removes the cervix. Now, if you have a pap smear alone, and you are told that your pap smear is normal, then you repeat screening after 3 years. If you have both the pap smear and the HPV test, and you are told that both of them are normal, then you repeat screening actually after 10 years. But if you only have the HPV test alone, and you're told that the HPV test is negative, then you rescreen in 5 years. So screening for cervical cancer, the disease that is way much of a killer, that is only affecting Africa, can be reduced to 2 screening tests. If the tests are okay, you can repeat it in 10 years. So there is no excuse for not doing this one. Other screening tests that are very inexpensive, we can do a test known as via villi. Via villi stands for visual inspection under acetone or visual inspection under Lugol's iodine. Acetone is the normal vinegar that we use in our kitchen. We can also use it in the medical field. So this test is an office procedure. It's very cheap and the results are instant. If you decide to go this way, which is very inexpensive and very direct, then you can do screening every yearly because it's an office procedure that will only cost you 2 minutes of your time. So treatment for cervical cancer. Like we said, in the early stages, we can do surgery where we remove the cancer. But once this cancer has started spreading, then our only option is radiation therapy or chemotherapy. Now, you might ask yourself, what is this early stage that we can do surgery? Early stage that we can do surgery is when we catch the cancer before it causes any symptoms. Whenever there is a symptoms, a lady is bleeding after, whenever there are symptoms, a lady is bleeding after sexual intercourse, or they are having abnormal bleeding in between menses, you are already late for surgery, isn't it? Now, something that we need to know, and that's what I have been talking about, cervical cancer can be prevented. And in the Western world, they have managed to prevent it very well, because we know that almost all cases, 99.7%, are caused by human papilloma virus. And we know that human papilloma virus is spread through skin-to-skin contact, very intimate skin-to-skin contact, that is like sexual intercourse. And we know that there are vaccines for HPV. They are available. These vaccines are available. They should be given to boys and girls, because boys can also get the virus and spread it. Now, finally, when we are treating cervical cancer, we want to catch it before it becomes the cancer, when it still has what is known as precancer cells or precancerous lesions, so that you can be operated on and you don't develop the cancer altogether. So, these are news articles. These are news articles in local dailies. So, experts raise concern over low uptake of HPV vaccine in local newspapers in Kenya. That was the standard. So, experts raise concern over low uptake of HPV vaccine. So, why aren't people going for these vaccinations? Yet they are free, actually. So, another thing, this is a website known as The Elephant, unmasking the silent saboteur of how misinformation affected cervical cancer uptake. Finally, we have a third daily, girls in Kiambu set to start receiving free HPV vaccine. So the good news is that HPV vaccine, there are several types, but the most common is called bivalent vaccine, and it is available in Kenya for free. Kenya started with girls who are aged 9 to 14 because they want to catch these girls before they become sexually active. Because once you are sexually active, the risk that you've already contacted HPV is very high. So we want to vaccinate you before you get the virus. There is another type of vaccine known as nanovalent vaccine. It's available in select free private facilities in Kenya. That one is not free. So cancer care during COVID-19. COVID-19 became a big thing, and everybody has to talk about it right now whenever we are talking about any medical condition. So something to note is that getting vaccinated lowers the risk for severe illness of COVID. Hence, it is recommended for anyone with cancer or a history of cancer. So if you know a relative who has cervical cancer, breast cancer, prostate cancer, it's recommended that they go for COVID-19 vaccination, because you do not want to have COVID-19 in addition to cancer. So finally, I have take-home message or summary. If you've come in right now, or you fell asleep somewhere, or you forget everything that I've talked about, please have this one in your mind. This is the final slide that you should keep. So breast cancer, cervical cancer, and prostate cancer are public health problems, which means they eat a lot of the budget as far as their treatment is concerned. If right now you are found with advanced cervical cancer, you might exhaust every saving that you've saved for the rest in your life, for the rest of your life. So you don't want that to happen. So, and we've just said that their burden is on the rise due to demographic transition. People are living into their old age, and changes in lifestyle. That is a sedentary lifestyle, a lifestyle where we don't exercise, and we have high intake of animal fat, low intake of fiber diets, green vegetables, and state-specific antigen, PSA, which is a blood test for all men who are above 50 years old, and a pap smear and a mammograph for every lady who's above 40 years old. So pap smear, remember, they start at 25. But if you are 40, no problem, you are not late. So, as far as cervical cancer is concerned, HPV vaccines for both boys and girls. And remember, HPV has also implicated in other cancers. So which means if you take the HPV vaccine, you not only reduce cervical cancer, but you reduce other cancers, including rectal cancer and including cancer of the throat. So pharynx and larynx. And then another final message, if detected early, treatment outcomes are good. So let's not wait that, you see, I started bleeding. We sometimes get ladies who tell us in our clinics that I started bleeding 5 years ago. So you wonder, 5 years ago, what have you been doing? And then they say, right now the bleeding has become too bad. No, the first sign of cancer, palliative care, it's not curative care. We just try to bring a little bit of comfort into your life. So with that, I think I can welcome questions and we'll give answers.
Thank you so much, Daktari, for that amazing presentation. We have a few questions. The first question is from Caroline. She says, what is BRCT? I think you mentioned it somewhere.
Yes, so BRCT stands for breast cancer related antigen. Breast cancer related antigen. So it's a gene that some people have, others don't have. So if you have those genes, there are two types. There are BRCA1, BRCA2. If you have those, then you are at higher risk. We've seen 45 to 70% of getting breast cancer compared to the general population who do not have those genes.
Thank you. I think the rest is a testimonial. Someone says she has a living testimony of breast cancer, having been diagnosed in 2016 and went through treatment. We do not have a history of breast cancer in my family. My doctor told me it is sporadic. It starts from somewhere. Okay. The other one is about, what about eczema around the breast? Eczema around the breast?
So eczema around the breast, if it has been diagnosed as eczema, then there's no cause for alarm because the eczema is treated. It's an infection of the skin that is not related to cancer. Because remember we said that breast cancer starts from where breast milk is produced or the tubes that carry the breast milk. So if it starts on the skin, then you are safe because it has to start from inside. So if you have eczema around the breast, eczema is a skin condition that is not related to cancer. But a small but that we need to take care of. There is a special form of there is a special type of breast cancer that starts with something that looks like eczema, but that eczema is around the nipple. So to be on the safe side, if you get eczema around the nipple, have it checked out, because there is a special type of, one of the types of breast cancer presents as eczema on the nipple as the first symptom.
Wow, thank you for that. The next one is, does breast cancer come in form of a lump? I think you had answered that, but you can do that again.
Yes, breast cancer comes in form of a lump. And when we get the lump, we are still in the early stages because the breast cancer is still confined. The cancer is still confined inside the breast. But by the time we get to the lump, we are towards the late stages of the early phase. So we are still within the early cancer, but we are quickly running out of the early phases. So when you get the lump, don't sit on a breast lump. Quickly run to the hospital.
Thank you. The next one is, where is the BRCA genetics testing done in Kenya? And what is the price range for such tests? Don't know whether you have that information.
Okay, I was actually checking specifically for this information, but the person I called has not yet gotten back to me. But they have not gotten back to me on the price. But I was told KU can do the BRCA1 genes, and all Lancet laboratories can do them.
Okay.
And of course, the high-end hospitals, that goes without say, because whenever a high-end hospital lacks a test, they usually outsource it from India, from UK. So the question is our insurances able to pay for that? In KU, since it's a public hospital, insurance might cover, all insurances might cover a big deal there. So KU hasn't, which is a public hospital.
All right. Thank you. After 65 years, one cannot contract cancer. Is that what you said?
No. After 65 years, we stop screening for cancer, because there is a concept known as natural history of a disease. So what is natural history of a disease? Natural history of a disease is if you are to get the disease and no treatment is given at all, what is the effect? So let's go through the natural history of cervical cancer. So you get infected with human papilloma virus at your first sexual contact. Very bad luck. So probably at 16 years old, first sexual contact, you get HPV. HPV will struggle to form a permanent infection. It doesn't form the permanent infection as a standard. Actually, most of the HPV is cleared away by the body. But if it struggles and it succeeds to form a permanent infection, it will take about 2 years. Then from there, you shall move from acute HPV infection to chronic HPV infection. You still don't have cancer. You just have HPV infection.
Allah.
After getting the HPV infection, you are going to have to live with that HPV for 5 years before you get what is known as CIN1 or LCIL. LCIL stands for low-grade squamous interepithelial lesion. It needs 5 years for you to develop that. That is the first phase of precancerous lesions. Now, once you get that CIN1, you move from CIN1 to CIN2 to CIN3, and then now you get cancer. Each CIN needs an average of 3 to 5 years. Now, let's add all that together. 2 years for the infection to get chronic, 5 years to get the first precancerous lesion. Those are 7 years already. An average of 3 years to move from CIN1 to CIN2 to CIN3, each CIN. So CIN1, 3 years. We are already into 10 years. CIN2, 3 years, 13 years. CIN3, another 3 years, 16 years. Now you get cancer after that. So imagine you are 65 and you don't have any issue. Even HPV is negative and you are 65. So the earliest you will get cancer is 16 years from 65. Do you really want to be disturbed by, let us do a vaginal exam and check? So it's no longer worth it. That's why we stop screening once we reach there. But it doesn't mean you can't get it. You can get it, but you won't die from it. old age will have taken you.
Great. The next one is, if a man has some enlargement, is that a risk factor? Is medication enough?
So breast enlargement, that's not.
Is it
So
breast or the prostate? I don't know.
So prostate can never be in a mother. So at least you are talking of the cervix or the breast. Now the cervix doesn't become bigger. The cervix only gets lesions that bleed. It doesn't become bigger. But breast can become bigger if you are in the early stages of of breast cancer. So if you suddenly notice that your breasts have become bigger than they used to be, then that's a risk factor for cancer, and you should go get a mammogram. If the mammogram is not conclusive, you'll be sent for a breast ultrasound.
Okay, and what about the prostate? If a man's prostate has some enlargement, is that a risk factor?
No, that's not a risk factor. If prostate cancer does not also cause the prostate to become bigger. Usually, it just changes in its morphology, how it looks under the microscope. But there is another very common disease that is known as benign prostatic hyperplasia. It's not a cancer, but that disease causes the prostate to become big, and it causes men not to pass urine. So men come with something known as acute urinary retention. They are not able to pass urine, and that one is very, very, very common. When you go to the village and ask, 1 in 3 men will have that disease, and that's not breast cancer. That's not prostate cancer.
I get it. I get it. The last one, I think, is fibroids detected during ultrasound harmful?
So fibroids cause other issues, but they don't cause cervical cancer or endometrial cancer. So fibroids are the equivalent of the disease I've just talked about, which is called benign prostatic enlargement. So fibroids are not cancerous, but fibroids have the tendency of becoming very, very big and causing excessive bleeding that women come when they are anemic. But fibroids in themselves, they are not cancerous. And fibroids go away when women reach menopause.
Oh, they go away.
Yeah, when women reach menopause and we discover that they have fibroids and they are into menopause, we usually tell them that these ones are going to shrink. They shrink in menopause.
Okay. Beautiful, beautiful. I think that's the end of our questions, unless there is anyone with any burning question. Wow, it has been amazing. Thank you so much, Daktari, for that insightful presentation. Indeed, we have learned we are not where we were before we started. We have some information, and we'll continue learning and unlearning and relearning the best information that we have. So we want to thank you very much. We want to know, we partnered with you. We don't know where you are. Maybe, I don't know that it's you or Nancy who will tell us where you are and whether you can be our doctor.
Yes, I can be your doctor for all your gynecological and other needs. You can come see me. I'm at Scion Hospital. And as far as Scion Hospital is concerned, I'm actually part of the administration. I'm the medical officer in charge. So pass by. And as far as I'm part of the administration, I'm still a gynecologist. So for every other health-related problems, we will have a talk when you come. And you are very much welcome.
Wow, that's very, very good. Thank you so much for that. Ladies, I think we have come to the end of our presentation this evening, and we are delighted that you have been here. Maybe I'll just move a vote of thanks. Thank you, and I want to invite you now to join me in extending our heartfelt gratitude to Dr. Benoit for taking time to sensitize us on a topic of immense importance. I think you will agree with me. This is very timely. Daktari, you have shared invaluable insights and knowledge about breast, prostate, and cervical cancer. Your dedication to spreading awareness and educating us on these critical issues has left an indelible impact on all of us gathered this evening. Cancer is a word that fills us with fear and uncertainty, but it's also a topic that warrants our utmost attention. And you have not only enlightened us, but have instilled a sense of empowerment within us. And we now have the knowledge and tools to understand, prevent, and detect, and I think that is very important, detect these types of cancers at an earlier, more manageable stage. So thank you so much for taking your time to be out of your busy schedule just to be with us here today and answering our questions. And this is truly enlightening and an enriching experience. I would also want to thank the women here. I know they are joining us with their families, their husbands, their uncles, their brothers, their sons, you know, in the background, and want to say thank you very much. And I want to single out one of us in the Woman of Excellence platform, Madam Nancy Bessa. When I posted this in our WhatsApp platform, she readily said, yes, we can do this for you, Coach Lois. And I thank you for letting us learn from Dr. Benoit. So thank you so much. It is said, when you educate a woman, you have actually educated the whole village. So thank you so much, ladies, for joining us in big numbers this evening and for helping us take this information. We are calling upon you to take this information further to our families. So let us all commit to spreading this awareness to our friends and family, thus ensuring that the knowledge shared today continues to benefit our community. So thank you very much. And may we all strive to lead healthier lives with the awareness that you have imparted. And I want to say thank you so much. Once again, asanteni sana. Kindly tell us, where is Scion Hospital, S-C-I-O-N? Where is that, Nancy? Where are you located?
Oh, thank you so much for the opportunity. Thank you, Daktari, for the informative session, the presentation. Actually, Scion Hospital, it's a 24-hour facility for both inpatient and outpatient. We have 3 branches. One of our branches is in Mwiki. Those who are living around Mwiki, we have a branch there, and it's an inpatient as well and outpatient. Another branch, we have it at Embakasi, Nairobi, and we are soon launching our main branch, which will be a level 4 facility at Imara Daima. We are launching our branch at Imara Daima in December, so you are all welcomed. At Imara Daima, we'll have 3 theaters, and actually it's a big facility. And also let me say something on diabetic walk. This month we are having it's a diabetic month. So actually what we've done, we are having a campaign, diabetic campaign walk. And we have sponsors on board. We have partnered with KEMSA. We have also partnered with different organizations who are coming on board, and Full Gospel Church. So those who are around, you can come partner with us. We have a walk, and later we'll go to Full Gospel Church. We'll give medication free of charge at Full Gospel Church at Imaradaima. So we are expecting more than 2,000 people we will attend to. It's a free medication, so you are all welcome.
Wow. Thank you so much, Nancy, and thank you for being a woman of excellence. That is our community.
Thank you.
Yes, yes, and thank you for exposing us to this amazing information. So ladies, if you have people who can join in the diabetes walk, it is free. You'll have your t-shirt there, you'll have medication. Kindly engage them and let them join. Wow. So thank you so much. Ladies, you have seen one of the factors was, what was it called? Sedentary lifestyle, where you don't exercise, you don't work out, you don't eat well, all those kind of things. And we have a cure for you in the book club. In the book club, we read and we practice these healthy habits. So welcome to season 14, starting in January 2024, where we are going to take this conversation further. Wellness is at the heartbeat, you know, it's at the heart of Blue Waters Coaching, and that's why we are having this kind of conversations. We do not only just study or elevate our lives in other areas, but we also take wellness very, very seriously. So that's why we are having this conversation. So thank you so much. It's already 8. We have kept time. Have a good evening. Thank you so much, Nancy. Thank you, Daktari, and thank you, Management of Scion Hospital. Have a good evening. God bless you. Bye-bye.
God bless you.
Thank you very much, and good evening too.
Good evening. Thanks. Bye.
Thank you.
Bye.
Good night.
Bye. Good night.